Good evening, Doc.
Yeah, great. I think we can start.
Sure.
It should be a brief session, so hopefully we should be done in the next 40 minutes. So today we'll look at the management of ischemic heart disease in the emergency setting. And then we would also look at the management of cardiac arrest in the emergency setting. As always, I say this is the emergency medicine aspect, so I expect that prior to coming for the lecture, you should have at least look at the slides so that you have an idea of what we're talking about. And last semester we did ischemic heart disease, so this would just be like a brief, review, and then we'll look at the management. And basically, I mean, as the name suggests, ischemic heart disease, if you look at the name itself, it tells you what the whole condition is about. Okay, we know that the heart has its own blood supply. It's supplied by the coronary, vessels, and sometimes you can have periods where the blood supply to various aspects of the heart is sort of compromised, or this blood supply is blocked in various aspects or various parts of the heart. And once this happens, if it should happen for long periods, then you expect that the oxygen delivery to that aspect of the heart would basically won't go as it's supposed to go. And without oxygen, we would move from an ischemia and would end up developing an infarct. Okay, so basically that's what's the general idea about ischemic heart disease is. We are looking at the blood supply to the heart. We are looking at conditions or moments where the blood supply to the heart is compromised because probably there's some sort of blockage, or maybe the blood vessel undergoes some sort of change, probably some sort of spasms. And at that moment where this change occurs, there's a period where various aspects of the heart fails to be supplied with blood, which of course we are looking at oxygenated blood, so fails to receive oxygen. And without that poor tissue perfusion, you are going to have some sort of ischemia and some sort of infarct. We say that ischemic heart disease is like a major term, the umbrella term, right? And under this umbrella term, we have stable angina, and then we have the acute coronary syndrome, which is basically another umbrella term composed of your myocardial infarctions and your unstable angina. Okay, so the main heading when it comes to conditions leading to poor perfusion of various aspects of the heart is ischemic heart disease. And then under ischemic heart disease, you have your stable angina and then your acute coronary syndromes. The stable angina is usually, basically it's not an emergency, right? If you look at the characteristics of stable angina, the pain characteristic would be a little bit similar to what you would find when you are looking at the acute coronary syndromes. But in the stable, and usually with stable angina, even though it would give you retrosternal chest pain, which would radiate, sometimes it goes to the arm, it can go to the neck. I mean, mimic something like an acute coronary syndrome. This pain will usually not last for so long, and most of the time when it happens and you give some form of vasodilator in the form of nitrate, you are able to improve the condition. Whereas in acute coronary syndrome, once the pain starts, your nitrates, your glycerol trinitrates or your isosfenol dinitrates won't help the situation. And so the pain is able to persist for a very long time, and it can lead to mortalities if not managed on time. Your stable anginas would usually not give you that. all of us have one way or the other experienced stable anginas. Sometimes you stress yourself so much, you're running, you're walking so fast, you're doing some sort of physical activity, and then you feel the sharp pain in your chest. Okay. Most of the time, that's a form of stable angina. So in stable angina, you have a central or a retrosternal chest pain, which can radiate to the neck, the jaw, and whatnot. But usually, this pain wouldn't just appear on its own. The pain is usually provoked by physical exertion. Okay, so once you exert yourself, that is when you can have the impact of stable angina. Whereas your acute coronary syndrome, you don't need to exert yourself. The pain can just come when you are relaxed. Okay, and when it comes, it's that severe, and that is the emergency aspect. Okay, so if you go through your slides, in stable angina, usually you have some form of atherosclerosis or maybe a brief moment of cold, and then basically at that moment where there's a spasm, there's a pain, and when it opens up, the pain will just go away. So with that, we don't worry too much. Of course, once we realize you have stable angina, we'll counsel you, you need to exercise well, you need to make sure you are eating the right things at the right time, you're not eating late. The focus is basically cutting down all your risk factors to atherosclerosis, because that's like one of the major features of ischemic heart disease. So the focus is just cutting all such risk factors down. So avoid smoking, exercise, moderate intake of alcohol, make sure you're getting enough sleep, all those things, lifestyle modification or positive lifestyle practices that we tend to learn and educate our patients on. If you're looking at the pharmacological aspect, as I said, stable angina, usually once you give your nitrates, your patient is fine. Okay. When they come to you in the facility and then they have the symptoms, you just give your aspirin, and then you can discharge on long-acting like nitrates, like your azoxystrobin nitrates. Okay. We foresee the risk of developing an ischemic heart disease. So in such situations, we try to put them on some form of antiplatelets. We try to put them on some form of prophylactic statins, basically, or should I say antilipidemics, so that you can prevent the formation or progression of an atherosclerotic plaque. Okay, so we put our patients on those things, and those are like, it helps your prognosis when you are managing your hypertensive or your diabetic cases. So this is usually not emergency. This is what we do to prevent things from getting serious. And when your patient gets some form of stable angina and comes to you, you know that with your GT and your patients will be fine. Thing about the stable angina is that most of the time, patients, by the time they even leave their homes and they get to their facility, they've already gotten relief and they are fine. Okay. However, our worry and our focus today would be on the acute coronary syndromes, because that is the concern of emergency. Angina won't kill the patient. The acute coronary syndrome, especially the myocardial infarction, will kill the patient. As the name suggests, there's an infarction of the myocardium, means that a part of the myocardium or myocardial cells will basically die because there's poor perfusion to that area. Okay, and you remember in the acute coronary syndrome, we said we have ST elevation myocardial infarction, which means that your coronary vessel supplying the myocardium becomes totally occluded. Okay, then you have your non-ST elevated myocardial infarction. There's an occlusion, severe occlusion. However, you don't have complete occlusion of the coronary vessel. So this is also an emergency However, the prognosis for non-ST elevation myocardial infarction is better than the prognosis of ST elevation myocardial infarction. Okay, and there's also unstable angina, which one way or the other resembles a non-ST elevation myocardial infarction, because in this case, there's some form of narrowing. However, the main difference here is, as you can see, the other ones infarction attached to their names, but unstable angina doesn't have infarction attached to its name. So it tells you that your unstable angina at that point is not going to lead to death of myocardial cells. That's the main difference. And so in laboratory investigations, once a patient has that form of chest pain for a very, very long time and it's severe, and you're giving your GTN, it hasn't resolved, then you are looking at acute coronary syndrome. You know that clearly this is not a stable angina. This will belong to the acute coronary syndrome. Now, the onus lies on you to try to tell us what kind of acute coronary syndrome we are dealing with. And in such scenario or such situations, you do two important investigations for us. You do your ECG, and then you do what? Your cardiac enzyme, specifically troponin. When the results come and already you've made a diagnosis of acute coronary syndrome, all you want to do now is to know what type of acute coronary syndrome the patient has, because your management or your definitive management is actually going to be based on which type of acute coronary syndrome the patient has. Of course, if a patient has ST elevated myocardial infarction, it tells you that you need to go hard in the management, or you even need to do a bypass. The patient might go beyond just requiring medication to requiring a cardiac surgery because there's a total occlusion, right? So the management would vary depending on the type of acute coronary syndrome you have. So let's say your cardiac enzymes come, troponins, they come, and then they tell you that the troponin, the value you can see there is normal. Troponins would appear in the blood when the myocardium is damaged, right? So if the values are normal, then it means the myocardium is not damaged. Then confidently you can say, oh, patient has an acute coronary syndrome, but then troponins are fine. So clearly there's no damage to the myocardium, which means what? There's no infarction. So this is what? An unstable angina. Okay. If it comes and troponins are elevated, then patient has an acute coronary syndrome. Troponins are elevated. So clearly, this would remove unstable angina from the equation. We are dealing with a myocardial infarction because troponins are elevated, which tells us that the myocardium has been damaged. Now, the next thing is, what kind of myocardial infarction are we looking at? And that's where the ECG requested for initially comes in. We take a look at the ECG, and you're basically going to look at what we call the ST segment. If you look at this ECG here on my screen, this is the ST segment. Let's transfer it here. This is the ST segment. So if you take your ECG, you're looking at the ST segment. You know why it's called the ST segment? Okay, if you take a look, you have Q, R, S, and all the way T comes here. That segment between where the S, if you go Q, R, S, segment between where this S starts and where this T starts. The T starts from here. It doesn't start from here. It starts from here. That interval becomes your what? QRS segment. Okay. So this is it over here. Let's say we just oppose it here. We say this is a ST segment. This is a normal ST segment. If you take a look at the ECG, and this straight line here is rather in the form of a mountain like this, then you say this is ST elevation. Then it means that you have your diagnosis. This is what ST elevated myocardial infarction. Clearly, it is supported by your ECG, and it is also supported by your elevated troponins. Okay. If you take a look at this one, the same ST segment we talked about ideally supposed to be at the same level, as you can see, it's supposed to be at the same level as, where the P wave starts and so you expect that, your ST segment is supposed to be somewhere here on this line. But you can see that the ST segment now is below the baseline. Okay, so then we say that the ST segment has become what? Depressed. So this will be termed as what? ST segment depression or non-ST segment elevated myocardial infarction, what we call NSTEMI, which means that even though there's a severe occlusion, the occlusion is not total or it's not complete. So the myocardium is damaged, all right, but then there's still some form of perfusion, which is very, very minimal. Whereas here means that once ST segment is elevated, myocardium is totally, the coronary arteries are basically totally occluded. Myocardium is damaged. There's no perfusion of that aspect of the myocardium that is damaged in any way whatsoever. Okay. Do we get the differences between stable angina and then acute coronary syndromes and the differences between the acute coronary syndromes? We need to understand before we move on to the next one, which is the management. So if you have any question, please ask.
Sir, please, can you go over the ECG again, please?
Okay, so there's a normal ECG, as you can see. You have your P wave, you have your QRS complex, you have your T wave. There's a segment between the S and then the start of the T wave, and this segment is called the ST segment. When you are thinking your patient has an acute coronary syndrome, you are thinking of doing two investigations to confirm what you have. One is an ECG, two is cardiac enzymes, okay? You go ahead and you do your cardiac enzymes. Your cardiac enzymes, which is troponins, basically, it comes back and it tells you that, oh, cardiac enzymes are fine. Then, there and there, your diagnosis is shifted away from myocardial infarction. Because if you have a myocardial infarction, your cardiac enzymes, troponins especially, won't be normal. It will be elevated. Myocardial infarction means the myocardium is damaged. So if it comes and your troponins are fine, then it means you're not even dealing with a myocardial infarction, but you are dealing with what? An unstable angina, okay, which is also a form of acute coronary syndrome. But in this case, myocardium is intact and not damaged. Okay, but then you can also say that a patient who has recurrent unstable angina would eventually end up developing a myocardial infarction because it's more like a risk. It's a warning that, okay, you have some form of occlusion, but if you don't take care, occlusion will become that severe and you end up developing what? Myocardial infarction. With your unstable angina, there is a risk and it's supposed to prompt you to be very apt in terms of your management. Now let's look at the ECG. Let's say cardiac enzymes have come, it's fine. So we've able to sort out our legs and we know that, oh, when the cardiac enzymes came, troponins were high, so this is a myocardial infarction. Now the next stage is to know what kind of myocardial infarction we are dealing with, whether we are dealing with an ST segment elevated myocardial infarction, which will mean that the coronary arteries are totally occluded. And so you need to be aggressive with your management. Okay, or we are dealing with a non-ST elevated myocardial infarction, which means that the coronary arteries, even though they are severely occluded, you still have some space in the coronary arteries, and the myocardium, even though it's damaged, is still receiving some small supply of blood. Okay, and as I said, it means the prognosis will be better than the ST segment elevated myocardial infarction, which means total occlusion. Looking at the ECG here, let's say bring it here. Okay, this is just a schematic diagram, but if we look at what is on the proper ECG paper, you can see your P wave, QRS complex, your becomes your ST segment. The ST segment, we expect that should be along the same line as the baseline. This is the baseline, okay? So it should be on the same line for us to say it's normal. If your ST segment deviates from the baseline, then it means that your ST segment is not normal. Okay, so if the ST segment should deviate from this baseline here and go up, then we say the ST segment has become what? Elevated. And that means that you have what? An ST segment elevated or ST segment elevated myocardial infarction. Okay, that's what it means. However, if you check and it is deviated, but then it is deviated towards the lower direction, as you can see, this is your baseline, but your ST segment is rather below the baseline, then it means that you have what? An ST depression. So clearly this becomes a non-ST elevated MI. That's the opposite of your ST elevated MI. This is become a non-ST elevated MI. Sometimes if your cardiac enzymes come, that's your troponins come, and then it shows that it is elevated, and you take a look at your ECG and you don't find anything, you don't find any elevation, you don't find any depression, that would also qualify as a non-ST elevated MI. So a non-ST elevated MI, the ST segment will either be depressed or it will be what? Normal. Are we okay?
Yes, sir.
Yes, sir.
Okay. Now don't get confused, the last bit of it. So now the question will be, so what about unstable angina? Let's say you are thinking this an unstable angina, you've requested for your troponins. Your troponins haven't come yet, but all you have is your ECG first. If the ECG comes and the ST segment is elevated, you only need the troponins to come and support. If the ECG comes and the ST segment is elevated, you can make a diagnosis of what? ST segment elevated myocardial infarction. Okay. However, if the ECG comes and the ST segment is normal, it can be that this is actually a myocardial infarction, but it's a non-ST segment elevated myocardial infarction. Only the troponins can come and confirm, or this is actually an unstable angina. Okay, unstable angina would look the same or similar to a non-ST elevated MI. Do you understand? The only difference is you need to wait for your troponins to come so that you say, oh, even though the ECG of non-STEMI and unstable angina is the same, when the troponins came, the troponins were normal, so this is an unstable angina. Or when the troponins came, the troponins were elevated, so this is a non-ST elevated myocardial infarction. So you need the two to be able to make a very, very good diagnosis. Are we okay?
Yes, sir.
Yes, sir. Yes, sir.
Okay.
Sir,
Okay, good. Yes.
sir, so what happens if you wait for your troponin results and it's not elevated? Can it be the case?
If your troponin results
that.
come and it's not elevated, then it's good news. It means
Yes.
the myocardium is not damaged. So it means
But
you
your
are,
this thing,
Mhm.
yes, but your ECG is telling you that it's ST or non-ST.
Yeah, so if your troponins come and it's not elevated, right? But
Yes, sir.
your what will make you confused
Your
is
ECG
your ECG
ECG,
might say
yes,
that,
sir.
okay, the ST segment is depressed. That
Yes,
can
sir.
also be an unstable angina, as I said, because there's no
Okay.
infarction. Once your troponin levels are fine, there's no infarction, there's no myocardial damage. However, your troponin levels cannot come back normal, and then you have an ECG looking like this. If you have an ECG looking like this, which means ST segment elevated myocardial infarction, which means that there's total occlusion, your troponin levels will never be normal. It will be elevated. If it comes and your troponin levels are normal, you need to repeat the investigation because this is enough to tell you that the patient has MI.
Okay, sir.
Okay. So in terms of your management, basically, what is the patient lacking? The patient is having the infarction or there's a blockage there, and this is causing the patient to lack some form of oxygenation. As always, basis of emergency medicine, ABCs, very vital. Because once the patients, they rush the patients in, you don't know what you are managing. So you need to assess airway, breathing, circulation. Very, very important, right? In terms of your management, if now we are thinking, all right, okay, so this could be an MI because the patient has severe, because the symptoms are what will prompt you to, let's do ECG, let's do cardiac enzyme. Because if the patient comes holding the chest, left-sided aspect of the chest, and saying that the pain is so severe, it's unbearable, it's moving all the way to my left shoulder, it's coming to my neck. If you don't know that this history points to some form of ischemic heart disease or acute coronary syndrome, you won't even be prompted to say, oh, go and do troponins. You won't be prompted. You say, oh, let's do X-ray and let's see. Maybe patient has a pneumonia with some very, very bad pleuritis, and that's why the patient is having pain. By the time you go and do ECG and come, the patient is dead. So you need to know the history. So you need to go through the slides and know how they will present. I have indicated that in the slide. And once you know how they will present, you know, okay, this looks like an ischemic heart disease. I don't know what I'm dealing with here. The first thing is, okay, let's try and resuscitate ABC. Let's give her oxygen. Let's give the patient GTN and let's see if maybe it will come down. Most of the time, it won't resolve because then it will only resolve if you have a stable angina. But most of the time, it won't resolve because this is an acute coronary syndrome. And one of the characteristics is it doesn't resolve when you give your nitrates. It won't resolve. Okay, so that's it. But for what it's worth, you need to give. What if the patient has some form of stable angina and then probably the patient has, should I use hysteria? The patient is so anxious that because of that stable angina he had, this patient is very rich, doesn't want to lose his or her money, so he doesn't want to die. The patient will just freak out. And even with that stable angina, patient might still perceive that, hey, I still have pain. So you need to give the GTN if you have, or any form of nitrates if you have, just to clear any doubt. If you give pain is still persistent, it tells you that no, this is not a stable angina. You're dealing with an unstable angina. Okay, so your oxygen is going. Usually, you need to give aspirin or clopidogrel about 150 to 300 milligrams start. I like giving 300 milligrams start. Then I do a daily follow-up of 75 milligrams daily. Okay. Then you need to anticoagulate your patient. Okay, so you need to give your patient some form of anticoagulation. So prophylactic anticoagulation. So yeah, looking at doing subcut fragment of 5,000 international units or subcut Clexane of 40 to 80 mg. Of course, this the Clexane, you know, is a brand name. The fragment is also a brand name. So you should know what they stand for. Fragment is dalteparin, Clexane, and enoxaparin, and these are low molecular weight heparin. If patient doesn't have any form of contraindication, okay, you need to know the contraindications. Do you have any bleeding condition that you tend to bleed easily? Have you had any hemorrhagic stroke within a certain period of time? You need to find out from the patient relative or the patient themselves. You need to be sure, okay? And then you go ahead and then you give your anticoagulants. The next thing is your focus is on breaking down the clot or whatever is blocking the blood vessel, okay? So you need to institute a fibrinolysis by giving a fibrinolytic agent or an agent that goes to break down, lyse the fibrin and basically break down whatever is blocking the pathway of the blood flow. And that's where your recombinant tissue plasminogen activators come in, your altiplase, reticlase, and nicteplase. That's where they come in. So you start an infusion of that for the patient, okay? And then if there's any form of thrombus sitting there, it's basically going to break it down, and then it's going to improve the reperfusion. Okay, so those are like the major things you do for the patient. As for the pain, you can go ahead and give your morphine. And then, of course, whenever you give, you're giving some metoclopramide so that the patient wouldn't throw up because of the side effect of the morphine. Okay, so that's what you do for your patient. And then you just monitor vitals while the patient is there. When it's time for you to discharge the patient, you need to make sure that whatever place this patient at risk of developing this acute coronary syndrome is addressed. So if a patient is hypertensive, you need to make sure BPs are well controlled before going home. If patient is diabetic, you need to be sure that sugars are fine. If patient has hyperlipidemia, you need to put the patient on some high dose statins, okay? And if the patient, is hypertensive, we know that in terms of their BP medications, you can throw in some ACE inhibitor, ARB. As I said the other time with the acute LVF, it prevents cardiac remodeling. Cardiac remodeling here means that the ischemia is eventually going to lead to an infarction, which will lead to dead or scarred tissue. Scarred tissues won't, contract and relax easily in the myocardium. So that's going to affect contractility of the heart. So you need to give your ACE inhibitor, ARBs. This
I would like to
Yes, please ask a question.
yes, this is the case we are proving as an emergency case. So after, as you are going through can you use the cardiac monitor to also check for the whether it is an STM or STEMI or non-STEMI? Or can you also do the bedside? You can do the bedside ECG.
Yes, exactly. I mean, with this kind of ECG we are talking about, that is what we are even talking about. ECG by the bedside so that we know what we are dealing with. But ideally in the emergency setting, you are right, we should have cardiac monitors there. The main reason we'll know why shortly, because that will be the next topic of discussion. Once you have conditions like this, like some form of MI, okay, which is that severe, or you even have what we talked about the other time, you have some acute LVF. When it's that severe, you can end up developing a cardiac arrest. And when you have a cardiac arrest, you can't manage a patient with cardiac arrest effectively without a bedside monitor.
Okay.
So, yes, so you need it for the patient.
Okay.
Yeah.
Yes. Right. Thank you.
You're welcome.
Hello,
yes, hi, Elisha.
I want to ask, when you are looking at the P wave, that means you are looking at the atrium, and the QRS is complex, it focused on the ventricle. I want to know the ST segment, what we are looking at here.
You said when you are looking at the
ST segment, what are we focusing on?
I'm coming. So you want to say if the P wave is atrial contraction and then the QRS complex is ventricular contraction?
Yes, sir.
So this segment, basically, if you look at the cycle of the heart, how does the cycle of the heart go? There's a contraction, and then there's a period where the heart relaxes. So if you remember your action potential and whatnot, there's a certain period where there's deep depolarization, and there's a certain period where there's repolarization. You remember?
Yes, sir.
Good. So basically, when you are looking at the ECG, and we are saying P wave is atrial contraction, and afterwards you can see there's a moment where you have your PR interval, and then QRS complex is your ventricular contraction, what would the ST segment mean? Just look at the ECG and then take a wild guess. Hello, Elisha.
Hello, okay. Please.
I want you to take a look at the ECG, which is projected on the page.
Okay.
And we are saying P wave means atrial contraction, and there's a QRS complex, which means ventricular contraction. And in between, we are saying you have contraction and relaxation. So what would the ST segments mean?
I am thinking it will be how the relaxation of
Did you do physiology? You guys did physiology, right?
Yes, sir.
Exactly. And so people did a cardiac cycle.
Yes, sir.
Good. So this one should be cool, right? And so someone should talk to me.
There is a period where the ventricle relaxes. The period between each of the cardiac cycle.
It's a period where
The short period where the heart relaxes, the ventricle relaxes for the
okay. I didn't hear what you said at the other parts, but I heard relaxation, so we'll take it like that. So yeah, so that is what we are looking at.
Someone to call Elisha. Elisha is disturbing me.
Elisha, are you okay now?
Yes, sir.
Okay.
I'm okay. Thank you.
Welcome. So basically, that's what we are looking at. Okay, so basically, that's what we do for our patients. So we discharge them on a beta blocker because we don't want a situation whereby the heart is beating so fast. Because once it's beating so fast, it means it will consume more oxygen. A lot of.
In my side too.
So yeah, so basically, you go ahead and then you do a surgery for the patients, right? And the focus is on restoring the perfusion. So you can either do a percutaneous coronary intervention, okay? And you do that for your patient. So you are basically going to go through the skin and then do some form of angioplasty for the patient. So you are going to go through the skin, you are going to pass a stent in there. You can see this occlusion here, right? So you pass a stent, the stent goes in, and then you're able to inflate, if it's like a balloon or whatever it is, you're able to inflate. So it pushes this plaque, which was initially occluding, it pushes it back. And now you've got space in there, and then you can have your flow going through. So you can see something similar here. Bypass. As you can see, look at where this is. Okay, you can see that this is where the occlusion is. And this occlusion over here doesn't allow blood to move freely to this side. So you come and you put the bypass here, and then you graft it to a side distal from the occlusion. If you come and put it here, it means you've done cost 90 because it means blood will still not be able to flow from here downwards. So you come and then you put the bypass here. So apply this aspect of the myocardium. Okay. So basically that's what we will be talking about. So when we are looking at ischemic heart disease in the emergency setting, management is quite straightforward. Of course, if the patient is lying down, it's not going to be like stepwise, oh, do this, and then your patient will be fine. You are going to struggle in managing the patient. So in cases like this, you don't manage alone. If you are in a site, a locum joint, or maybe you are far away and you are alone there, you are basically short of resources. So all looks, it depends on what is preceding the question. Okay, so you complete your question and let me see.
So assuming they say you are in a health center.
Yeah.
So let's just take the health center and they say, how would you manage? Do you get it? It will not be like what you have stated here.
You know, they will, unless you see in the exams, they won't ask you because they are training you to practice in a bigger facility. So they will never. So
it's not true.
A smaller
no, of course, no, they will post you to a smaller facility. States. So if I were to be you, I'll write on oxygen. Okay. After writing on oxygen, as is stated there, I'll give high dose aspirin. I'll give anticoagulation. And then I'll state that continue, blah, blah, blah. Or they can, yes, you see, you see a question like that, okay? And they'll say, maybe, assuming you are a physician assistant with at the Acute compound in Aeds or something, how will you manage this patient? And you see 10 marks there. Then you go and write, okay, I'll resuscitate, airway, breathing, circulation. Then I'll give oxygen, I'll give high dose aspirin. And then because I'm in a CHIPS compound, I will refer.
So sir, suppose this ECG thing comes in, maybe your investigations.
Yeah.
Would you go ahead and state all the ECGs since you don't have them at there so that will you go ahead?
But
and
how would the examiner know that there's ECG at there so or not?
Maybe
ECG and you see, so because listen, ECG is supposed to be a basic thing that you need. Ideally, you need to get ECG in every facility, health facility in Ghana, whether it's CHIPS compound, health center, district hospital, whatever. You are supposed to get it there. So you do yourself harm if you say, oh, I'm right, because I don't think others will have ECG. Meanwhile, you know that you need ECG in your diagnosis. If anybody should set a question like that, they just want to confuse you.
Okay, sir.
Today I received a message from one lecturer from the institution, Radford. He texted me and she told me what she said is actually the truth. You don't leave anything to chance. Do you get it? Yeah. So unless you don't know, but if you know, right, And if you know that this procedure is so big, maybe you do want to do an MRI as part of your management. Maybe they didn't ask you for investigations first. So as part of your management, you want to do MRI for the patient. You know that the CHIPS compound, you don't have MRI. You would state that an MRI patient, an MRI will be done for the patient. You don't state that, okay, we'll do an MRI for the patient. If you say an MRI will be done for the patient, it's open. It's either you are sending the patient in an ambulance to go and do an MRI, or exactly, you've left it open. And they don't expect that you write, I will call for ambulance and I'll put the patient in an ambulance to go and do an MRI scan. Because sometimes they just want to waste your time with this kind of question. So you'll be asking yourself questions. Should I even write MRI? This is a CHIPS compound. Should I? But then at the level of the CHIPS compound, you make referrals as well. And referrals are part of standard treatment guidelines or standard operation, practices. If you can't manage, you refer. You see, so you guys shouldn't be restricted. If you know, right, you get extra mark. Nobody will mark you wrong for saying that, he said you do an MRI, but we don't have MRI in a CHIPS compound. Whilst the MRI will be life-saving to the patient, nobody would mark you wrong. Are we okay?
Yes, sir.
Okay, so if the question hovers around the CHIPS compound, so at what point would you say, if ECG is available, you would do an ECG, and then perhaps if it's not available, you refer? Are you allowed to say that?
You don't say that you do an ECG if it's not available, you refer. State that you do an ECG.
Okay.
Like states, write it in there. But that's what I'm saying. I don't even ask you a question like that. Your question will be generalized and it will be universal and it will be standard. It will be opened for you to be able, because this is MDC setting the question, not someone sitting in some, corner be trying to know. So they will give you standard questions. We even try to give you standard questions. So far, have you seen any of your lecturers set questions like that, you find yourself in, and then they try to restrict you? No, we want you to be expressive.
Okay.
Yeah.
Thank you.
Because mind you, we are not only teaching you to become physician assistants, we are teaching you to go beyond that. We expect that the physician assistantship, the BSc you get, will just be a stepping stone for you to get your MBCHB, your MSCs in various fields that you want to do, and even your PhDs. So don't feel restricted at all.
Okay.
All right. Please, beta blocker question. Let's take it.
Yes, please. So the beta blocker only comes in when you are discharging the patient, because that's what you said.
Yes. So it comes in when your patient is stable, basically. Okay. Because mind you, if you also have an MI and it's on the left side of the heart, this MI can actually lead to an acute left ventricular failure. And then you might end up having, it's all interconnected. So you might end up having what we discussed the other time. You might end up having a pulmonary edema. Usually you want to be a little bit relaxed about giving your how do you call it, beta blockers. Even if you are looking at selective beta blockers, you just want to chill a bit because you don't want to go and give anything that might compromise the patient's breathing. So usually once the patient has recovered, you've listened to the chest is dry. As in dry, meaning that you don't have any crepitations and whatnot over there. You are comfortable that, all right, okay, let me add some beta blocker to the patient and observe before I discharge. Okay.
Okay, thank you.
You're welcome. So, can you see my new screen now?
No. The classification.
Yes, you can see it. All right. So this is straightforward. So let's just touch on cardiac arrest and we can close. We've gone beyond our 40 minutes. So basically when we say what is cardiac arrest, okay, there's a sudden loss of blood flow to the organ system. And basically this would happen because the heart, which is supposed to be functioning as an effective pump, will fail to function as an effective pump. that is like something similar in heart failure, right? The heart fails to function as a pump to supply the body with the needed blood and all that. Okay. In this case, however, it's not just about the heart failing to act as a pump. When you try to get a pulse, you don't perceive a pulse, whereas in heart failure, you can perceive a pulse. So there are differences. So you can, people usually get confused. There's heart failure, there's heart attack, there's cardiac arrest. Heart failure is what we discussed on Monday. Heart attack is what we just discussed. The myocardial infarction in layman's term is heart attack. And cardiac arrest is what we are coming to discuss now. Okay, in cardiac arrest, there's no pulse. So if your patient is alive but doesn't have a pulse, then it means your patient is having a cardiac arrest. Are we okay with the definition? So don't let it confuse you in any way. Okay. So
the patient is alive but doesn't have a pulse.
Yes, patient is alive but there's no pulse.
Why?
Okay. Oh, it's possible. When you have a cardiac arrest, when we say the patient has cardiac arrest, come, let's resuscitate the patient. It's because the patient has no pulse. If you have your patient lying on the ward and then there's a monitor on the patient and you're hearing beep, beep, which is the usual heartbeat, and then all of a sudden you're hearing beep, meaning that the monitor is not picking up any heartbeat, any pulse, then it tells you that the patient doesn't have a pulse, but it doesn't mean that the patient is dead. You don't pronounce the patient dead.
Now means technically, if the absence of pulse doesn't mean
death. No. Okay. If it means deaf patients, then the football fans, you all know what happened to Christian Eriksen on the page during the Euros. If the absence of pulse means death, then that guy shouldn't be alive by now. He should be dead.
Okay.
So, sir, how is it different from coma?
Coma, there's pulse. Coma, there's pulse. Coma has to do with the neurology, okay, brain function. That is coma. You understand? Yes, so coma, you are looking at the neurological function, but coma, there's pulse. If your neurological function is gone and you don't have pulse, and you are lying down there, you go beyond 5 minutes, you are basically dead. But people can be in coma for years because there's pulse. The fact that you have a pulse means that blood is still flowing to your brain, which is the vital aspect of the body. Even though the brain is asleep, blood is still flowing there. We are hopeful that one day the brain will wake up. That is coma. But in cardiac arrest, there's no pulse. And if cardiac arrest persists for more than 4 to 6 minutes, then it means that blood hasn't got into the brain in 4 to 6 minutes. So the patient is most likely dead. Even if you resuscitate your patient after 10 minutes and your patient comes back, the possibility that your patient will be what we call a vegetable is very high, because the patient will wake up, but then a larger part of the brain will be dead. So even though the patient will come back and will be having a pulse, a larger part of the brain will be dead. So in managing cardiac arrest, you need to be timely. Your patient should be awake in less than 5 minutes. Like your patient should be up. Once you go above that, you are going to 10 minutes and things. We'll tell Charlie, stop doing the CPR, because even if the patient comes back, the patient is gone. And if the absence of pulse means that the patient is dead, then no one will bother to do CPR. True or false?
True.
Because why do we do CPR? We do CPR because we think, hey, there's no pulse. There's no pulse. So let's do CPR. Maybe we might be lucky. Patient will wake up. If patient is dead, patient doesn't wake up. If the patient is dead, patient is dead. But if there's no pulse and you see it early and you do your CPR, patient is at that point in between the living and the dead. So if you do your CPR fast and you get a pulse, your patient will come back to life. And that point in between the living and the death is what is called cardiac arrest.
Okay.
Are we okay?
Yeah.
Yes, please.
Okay. All right. Excellent. So remember I taught you that there are 4 different types of cardiac arrests. Mainly they are classified under 2 main groups, shockable and non-shockable, right? And shockable means that if we realize that you don't have a pulse and we shock you with a defibrillator, and as soon as we shock you, the defibrillator, we shock you once or twice or maybe once, the defibrillator is able to bring back your pulse, then it means what you had was a shockable cardiac arrest. It means that that type of cardiac arrest was, amenable to electrical shock. As soon as we shocked, you came back to life. So we say you have a shockable cardiac arrest or you've had a shockable cardiac arrest. If you have a non-shockable cardiac arrest and we shock you, you won't come back to life. Or the shocking will even make your cardiac arrest worse and it will kill you. So 2 things. And that is why I think who asked the question about the monitors. Oh. The name has escaped me a bit. But I think someone just yes.
Yours.
Yes.
In this case,
Yes. Yours.
is-
Yes. Yours asked question about monitors. So yes.
So if the person is brought in, or you walk in on someone, a patient, and you think the person has gotten a cardiac arrest, so how do you know that it's a shockable one or a non-shockable one?
Exactly.
Because you might go
Good
shocking
question.
the person and kill the person.
Good question.
If it's
So that's what I was coming to. And that's why I said that it was a very good question Yosin asked about the monitors. And in Ghana, it means we are killing a lot of management of cardiac arrest without monitors. Because without a monitor, you won't know. You can never know. You are not a magician to know what kind of waves you are having. Without a monitor, you never know. All the 4 types have specific waveforms, and you only know on your monitor. Without the monitor, you won't know. So you won't know whether you are shocking or not. So all of us doing ECGs, CPRs in the emergency room when the patients think there's no pulse and we are doing CPR. Okay, let's shock. Without monitor, we are doing wrong. We are doing wrong things. Okay, we are doing the wrong things. The other thing is there are something called AEDs. Okay, so these are like automated defibrillators. Okay, so once you put on the patient, you don't want that's automated defibrillators. They speak back to you. They are not like the pedals we see in movie. Then you go and take and then you shock. No, they are not like those ones. They speak back to you. So if you plaster it on the patient, it will speak back to you and tell you that the current wave is not shockable. So if it tells you it's not shockable, you know what to do. It means that do CPR or give some medication, which we'll be seeing shortly. And once you are doing the CPR or you give your medication, the medication or the CPR is able to convert the non-shockable to what a shockable type. And then as soon as the machine picks up that, oh, now we have a shockable wave, the machine would talk back and say, now waveform is shockable. And then you press and the machine will shock the patient. You get it? So those ones, you don't need a monitor. They are automated. But the manual ones, that's you use the pedals like the iron and you put it on the patient's chest. You need a monitor to see the waveform to shock. Okay, so let's quickly look at the types. So shockable and unshockable, we have what we call ventricular fibrillation and we have what we call pulseless ventricular tachycardia. Okay, as you know, just like atrial fibrillation, ventricular fibrillation means the heart is beating so fast and it's beating irregularly. And because it's beating so fast and irregularly, the ventricle is unable to contract fully to push blood into the systemic circulation. So you won't feel any pulse at all. Because if no blood is moving from the heart to the circulation, then it means no pulse. You only feel pulse when blood moves from the heart to the circulation. So when you touch the blood vessel, you feel something hit your hand. In ventricular fibrillation, you have no pulse at all. Okay, so this is how it looks like. So the ventricle, these are the ventricles beating, and it's all over the place. As you can see, it's in disarray, it's irregular, it's beating all over the place. The difference between this and the next one, which is a pulseless ventricular tachycardia, is that ventricular fibrillation is irregular, but then pulseless ventricular tachycardia, even though you have a tachycardia, ventricles are beating very, very, very fast. It is what? Regular. Okay. Basically, that's the main difference. Fibrillation, irregular, pulseless ventricular tachycardia is regular. Ventricular tachycardia on its own is not supposed to cause cardiac arrest. It's not supposed to lead to no perception of pulse. And that's why they've qualified it and they've said pulseless ventricular tachycardia. So it means this is not your usual ventricles beating fast, but it's beating so fast to the extent that it's not pushing blood into the circulation. And so there's no pulse. So when you look at the ECG, you see your QRS complex only, as you can see. But then there'll be what? Regular. You can see it. Compared to this, which is all over the place, QRS complex, which is all over the place. Okay, now let's look at this. The non-shockable, there are two types. We have pulseless electrical activity and we have asystole. Pulseless electrical activity, when you touch the patient, there's no pulse. But when the monitor is connected to the patient, you can actually see a normal ECG. So there's normal ECG, but then it's beeping like there's no pulse. Pim, 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 pim. If you try to palpate pulse, nothing. But then when you look at the monitor, it gives you a normal ECG. That is called pulseless electrical activity. Okay, it means that there's some form of electrical activity, but this is not generating, it's not sufficient enough to generate any pulse. And then the last one is asystole, which is the usual flat line that we see when we are in the ER and someone dies. You see a flat line, means that the ventricles are not contracting at all. So there's a flat line, it's called cardiac standstill. And that's what you see when a patient dies. Okay, but the fact that you see asystole, flat line, doesn't mean that the patient is dead. If you see it early, you can resuscitate and then bring the patients back to life. As we said, if it's shockable, you shock. If it's non-shockable and you shock, patients won't come back to life. So how do we manage? The basic things you need taught when you go to the simulation center: administer oxygen, defibrillation if it's shockable, or if a non-shockable is converted to shockable, you defibrillate the patient. And then, of course, your monitoring, which is very essential. Also, drug therapy, epinephrine or adrenaline and amiodarone, which is used basically if you have non-shockable to convert the non-shockable diagram, as you can see over here, which basically tells us how to handle CPR, okay? CPR for our cardiac arrest, and then it also looks at other aspects of managing cardiac arrest. So as soon as you realize that the patient has no pulse, the first thing you do is you connect your monitor quickly if your monitor is not connected, so that you know what you are dealing with. Then you start a CPR. Okay, CPR means was chest compression and then ventilation, right? So you learn how to do quality CPR very soon. And then you look at the monitor to ascertain the rhythm. So if the rhythm is shockable, you know what to do. If it's not shockable, you know what to do. So that's the next one. So you look at the rhythm. So when we check the rhythm on the monitor, we saw that, oh, this is a ventricular fibrillation or pulseless ventricular tachycardia, which means that it's shockable. So let's go ahead and shock the patient. So you shock, and if you shock once and your patient comes back to life, you're in the money. If you shock once and your patient doesn't come, you do another CPR again for 2 minutes. You continue your oxygen, you set your IV line, then you shock. Okay. Basically, if you shock and then it doesn't work, you do CPR, you give adrenaline, 3 to 5 minutes, you shock. Do you get it? And then if that one also doesn't work, you continue CPR and then you give amiodarone. But most of the time, if your patient will come back, by the time you are done with your amiodarone, your patient should be back. If you go through all these stages, sometimes you can just go through just one stage without even needing to set an IV for your adrenaline or get into the amiodarone stage. Usually after first CPR, shock, patient comes. Okay. If there are no signs, then you come back here, you do a CPR, and then you check. If you go beyond that time that we are all talking about, that we know that after 6 minutes, even if the patient comes back, the brain is there. Sometimes we say continue CPR for 10 minutes. Okay. If you go beyond that, your patient is gone. You have to pronounce your patient dead. If you are lucky and at any of the level here, pulse returns, then we just focus on our patient and then manage accordingly. If we do the CPR, we check, and then we say, hey, this is not shockable. So maybe we are dealing with a flat line or a pulseless electrical activity. The next thing is to what? Give the patient adrenaline. Arrest, which you have in your slide. Okay, so basically this is an algorithm that you need to follow. If you look here, you can see the you treat the reversible causes. You can see the reversible causes listed here. Maybe the cardiac arrest is due to some hypovoluemia. To this algorithm. First of all, you want to know whether you have a shockable or a non-shockable type of cardiac arrest. So you set up your monitor, you look at your monitor, and if it's shockable, you go through this. If it's non-shockable, you go through this. Non-shockable, your focus is giving a medication to convert it to what? A shockable type. Then you come and use your defibrillator to shock your patients back. Yeah, I can hear you.
What if there are no tests at where you work?
Hi.
Yeah. Yes.
Hello,
I forgot to add. I received some pound sterling from your class. From your class. I'm very grateful.
So we are also
I appreciate it a lot.